Hello students, this is Dr. Madhavi Kevle, MBBS MD Anatomy, and this is the second part of the lecture on larynx. So let's begin. So at the end of this lecture, the student must be able to describe the anatomical aspects of laryngitis. He should be able to write the anatomical basis of cadaveric position of vocal cords, singers, nodules, laryngoceles, and he should be able to write short notes on topics like recurrent laryngeal nerve, the subdivisions of laryngeal cavity as seen in the coronal section, the short notes about laryngeal inlet, and some notes about the vocal cords. Also, the students must be able to draw the diagrams of coronal section of laryngeal cavity and laryngoscopic view of laryngeal cavity. And you should be also aware about the different steps in phonation. So let's begin. So before you start on the journey of understanding of this lecture, it is very much necessary to go through the first part of the lecture, Larynx 1, which was published before this one. So now coming to the subsequent slides, what is laryngeal cavity? Now this picture here you see, let me take the pointer. In this picture, this is the coronal section of laryngeal cavity. Now let's make ourselves aware about the picture. Here you see this oval on this left side and the oval on the right side. So this is the hyoid bone in the coronal section. Now here you see the blue oval on both the sides. This is the cricoid cartilage. So the laryngeal cavity is extending from this point, which is called the laryngeal inlet, which is the laryngeal inlet lies between the two aryepiglottic folds on both the sides here. So this is the laryngeal inlet, and here this is the cricoid cartilage. So the lower border of cricoid cartilage, which is marked by this imaginary line. So this is the extent of the laryngeal cavity. So once again, the laryngeal cavity extends from the inlet of the larynx here up to the lower border of cricoid cartilage, which is marked by an imaginary line here. Now what are the boundaries of this laryngeal inlet? Now this laryngeal inlet, anteriorly to it lies the epiglottis, posteriorly lies the interarytenoid fold, and on both the sides, as seen in this picture, we see only the lateral sides. So in this picture we see the aryepiglottic fold of mucous membrane. Now this is the picture which has been repeated from the last lecture. This picture shows us the sagittal section of the larynx, in which we have to make ourselves familiar with the ligaments. Now from the last lecture you know that there is a quadrangular membrane, this big part between the extending from just below this epiglottis, this quadrangular membrane, and there is this cricovocal membrane here. Both are shown in the purple colors, and the lower border of this quadrangular membrane thickens to form this vestibular ligament. So this is the vestibular ligament, and the lower upper border of this cricovocal, it thickens to form the vocal ligament. So these two ligaments will form the our basis of understanding of the next slide. Let's go ahead. Now what are vocal folds or vocal cords? Sorry. So vocal cords are two pairs, means there are two multiplied by two pairs of folds of mucous membrane which extend from posteriorly to anteriorly. Postero-anteriorly they extend from where to where? From the arytenoid cartilage to the thyroid cartilage. So which are these two folds? The names of these folds are vestibular fold or false vocal cords and vocal folds or true vocal cords. Now let's see them one by one. The vestibular folds, which are also called as the false vocal cords, are produced by the vestibular ligament. This is the false vocal cords. This fold, it lies above, and the space between these two vocal folds, yes, between the false vocal cords, is called Rima vestibuli because it lies between the two vestibular folds. So the name given to this space is Rima vestibuli. And what is the function of these false vocal cords? As the name suggests, they are false vocal cords, means certainly they are not going to take part in formation of voice or called as phonation. So what they must be doing? The most important function of the larynx, as we have discussed before, is the protection. So protection from what? So it protects the lower respiratory tract from anything entering it or exiting. So that means that the function of the false vocal cords is the prevention of food and liquids from entering the larynx and air from leaving the lungs. So they don't let the food and liquid to enter into the lower respiratory tract, and also they don't let the air leave the lungs. Now let's see what are vocal ligaments and vocalis muscle, what they do. We have already seen what are vocal ligaments and vocalis muscles. These both of them, they form the vocal folds or true vocal cords. And what is the extent of true vocal cords? Between the thyroid angle and the vocal process of arytenoids. Now the space between these vocal folds is called the Rima glottidis, and Rima glottidis is the narrowest part of the laryngeal cavity. This you should always keep in mind. Which is the narrowest part of laryngeal cavity? It is the Rima glottidis. Now the vocal cords, they are just the mucosal linings of these vocal cords. They are formed by the stratified squamous epithelium. Now this mucosa is firmly attached to the underlying vocal ligaments, and in between the vocal ligaments and mucosa there is no submucosa. So there is mucosa and there is vocal ligaments, nothing in between. That's why, because of this firm adhesion to the ligaments, we see this vocal cord in pearly white color. It is pearly white and avascular because there is no submucosa, there are no blood vessels. So this looks pearly white when we see on laryngoscopy. So this is how we will identify the vocal cords on laryngoscopy. They look pearly white. And when there is laryngitis and there is edema of the larynx, since there is no submucous tissue in the vocal cords, so we do not see any edema of the vocal cords. But since there is irritation and edema and inflammation of the larynx, the surrounding structures to the vocal cords, that's why we see change in the voice. So also the last point here is that the vocal folds don't have any mucus glands. Now, as we were talking about inflammation, let's understand the anatomical basis of laryngitis. Laryngitis means inflammation of the larynx, which is caused, which leads to irritation of the vocal cords. So there will be edema in the laryngeal cavity and irritation of the vocal cords. Now, what will happen if there is irritation of vocal cords? There will be the change of voice, and this can be due to infection, irritation and overuse. Most common complaint of this is the because of laryngitis, which is the most common complaint, the patient will tell you that there is hoarseness of voice. And if there is severity, If the patient still goes on talking and talking, there will be total loss of voice. So now let's see the next topic, which is singer's nodules or vocal nodules. So what happens during vibration of the vocal cords? So when the voice is produced, when phonation happens, you know that the vocal cords, they will vibrate. So the point which is having maximum contact between the vocal cords is the junction between anterior one third and the posterior two third. At this point of maximum contact also happens maximum friction again and again in cases when the person is overusing the larynx, like in cases of teachers or pop singers. Again and again they are talking without a break. What happens? There is friction, there is irritation, and there is overuse. So because of this overuse, there appear bilateral and symmetrical nodules over these vocal cords. Let's see in this picture. So these are the vocal cords. This is the anterior, this is the posterior. Here we see the vocal cords, and they at the junction between anterior one third and posterior two third on both the sides. So both the sides, these are symmetrical nodules which are bilateral, and these are singer's nodules. So when such singers nodules appear, especially in singers or teachers, they are asked to rest their throat, or in a common language we say rest their throat, but actually it is the larynx that needs rest. So next slide, what are the subdivisions of laryngeal cavity? Now the laryngeal cavity, it is divided into three parts by these two folds that we have seen. Which are the two folds? The false vocal cord and the true vocal cord. So these two folds of mucous membrane, they divide the laryngeal cavity into three parts. Which are the three parts? Supraglottic compartment, glottic compartment, and infraglottic compartment. Now the supraglottic compartment is also called as the vestibule. Supraglottic compartment is also called as the vestibule, which extends from the laryngeal inlet up to the vestibular folds. And the infraglottic compartment is the one which lies below the lower border of cricoid cartilage, and the space between both these two supra and infraglottic compartment is called the glottic compartment. So what is the laryngocele? So laryngocele is nothing but there is dilated air-filled cystic swelling of laryngeal saccule. Now what is this laryngeal saccule? So when the air pressure in the laryngeal sinus is raised too much, like when somebody blows the trumpet, or when they blow into the glass in the glass factory to make this glass, they have a long pipe and they blow very hard into it, blow air. Or when you do weightlifting, at that time too much air pressure is formed inside the laryngeal sinus, and this leads to trapping of this air in a cystic swelling, and this is called as the laryngocele. So there, what do you mean by the saccule? The saccule is nothing but a narrow blind diverticulum that is formed, means the mucous membrane extends in the posterior superior direction between the vestibular fold and the lamina of thyroid cartilage. It forms a sac-like structure, this small blind diverticulum. And if it is inside the larynx, inside the cavity, still lying inside the extrinsic structure, inside the skeleton, then it is called internal laryngocele. But if it distends so much that it herniates through the thyroid membrane and goes outside the larynx, then it is called the external laryngocele. So in this picture you can see uh, this is the part, this part is the sinus of larynx, and this is the saccule. Now normally this saccule is present. This is the distension which is extending posterior superiorly. This is normally present on both the sides. But if a person, so this is the lower, there will be lower respiratory tract here, and there will be oral cavity above. So if the person is blowing too hard, is expirating air so that the trumpet will make noise, so the air has to be expired out of the lungs. So when the person is blowing too hard, he is doing very extensive expiration, very severely, very strong expiration. At that time, this small saccule will get filled with lots of air, and it will go on increasing the pressure, so slowly, and it will distend. So till it is inside this boundary, till it is inside the cytoskeleton, and by cytoskeleton I mean that it has not pierced the thyrohyoid membrane, then it is called the internal laryngocele. But if it has pierced the thyrohyoid membrane and went outside the laryngeal skeleton, then it is called the external laryngocele. So when it is present here, it is internal. When it pierces the thyroid, it becomes external laryngocele. Now what is the nerve supply of the larynx? Nerve supply of the larynx. The larynx, it receives both motor and sensory innervation via the vagus nerve. So vagus nerve is the main nerve which supplies the whole larynx. How? Not directly, but through branches. Which are these branches? Let's see. Now the recurrent laryngeal nerve. The recurrent laryngeal nerve, it provides both sensory and motor innervation, but not to the same parts. It provides sensory innervation to the infraglottis, that is below the inferior border of the cricoid cartilage, and motor innervation to the intrinsic muscles of larynx, except cricothyroid. Cricothyroid is supplied by the external branch, that is the external laryngeal nerve, which is the branch of superior laryngeal nerve. Now superior laryngeal nerve has two branches, internal laryngeal nerve and external laryngeal nerve. So the internal laryngeal nerve, it provides sensory innervation to supraglottis. Yes, and external branch provides motor innervation to cricothyroid. Please pay attention, both recurrent laryngeal and superior laryngeal both are providing sensory as well as motor innervation, but to different structures. So please keep in mind. So now all the intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve, except for cricothyroid, which is supplied by the external branch of superior laryngeal nerve. So it is also named as external laryngeal nerve. So now what happens if internal laryngeal nerve is damaged? If internal laryngeal nerve is damaged, since it is providing sensory innervation, there will be the anesthesia of mucous membrane. Of which part? Only the supraglottic part. So what will happen? There will be loss of this protective cuff reflex. And this protective cuff reflex, if it is lost, anything can enter. So you know that if we are talking and suddenly a mosquito comes and it tries to enter inside our larynx, we get a cough, and such any particle, any dust particle or any small insect, it cannot enter. It is stopped because of the protective cuff reflex. But if this internal laryngeal nerve is damaged, we will never have any protective cuff reflex. Thus, any foreign body can enter the larynx. So now, next point is if there is the problem with the recurrent laryngeal nerve. So now, if the recurrent laryngeal nerve is injured bilaterally, then what will happen? Since it is supplying the all the intrinsic muscles except for cricothyroid. So there will be problem with the movement of the what do the intrinsic muscles do? They help in the movement of the vocal cords. So if the vocal cords are not moving properly, so the voice is either weakened or changed. So there will be a weak voice or a hoarse voice, or if there is on both the sides, if recurrent laryngeal nerve on the left and the right, both the sides is bilaterally damaged, then there will be no voice. So when there is no voice, it is called as the aphonia. Now you know that recurrent laryngeal nerve is supplying all the intrinsic muscles except cricothyroid. So then cricothyroid is supplied by external laryngeal nerve. Now external laryngeal nerve is the branch of superior laryngeal nerve. So now if this external laryngeal nerve is paralyzed, what will be the effect? So cricothyroid is responsible for what? Tensing of the vocal cords and increasing the length of the vocal cords, and also to adduct the vocal cords. Adduction is what? Taking them towards the midline. So if they don't get adducted, that means the laryngeal cavity will not close. So what will be there? There will be no tensing of the cords. So there will be weakness of phonation, or again the voice will not be generated that well. Now coming to the arterial supply of the larynx. Arterial supply of the larynx, again it is just like that, below the vocal fold and above the vocal fold. Above the vocal fold there will be superior laryngeal artery, which is a branch of superior thyroid artery. Isn't that easy? And below the vocal fold, it will be the supplied by the inferior laryngeal artery, which is a branch of inferior thyroid artery. Now you know that between the superior vocal supraglottic compartment and infraglottic compartment lies the narrowest part of the larynx, which is called as the Rima glottidis. So it happens that this Rima glottidis will get dual blood supply. That means it will get the blood supply from superior laryngeal artery also and inferior laryngeal artery also. Now what is the venous drainage of larynx? So venous drainage of larynx, the veins, the superior laryngeal vein and the inferior laryngeal vein will drain in the similar fashion above the vocal fold and below the vocal fold respectively. And where do they drain? The superior laryngeal vein drains into the superior thyroid vein, and inferior laryngeal vein drains into the inferior thyroid vein. Now what is the lymphatic drainage of the larynx? So again above and below the vocal cords we have to describe. Above the vocal cords, they drain into upper deep cervical lymph nodes. Yes, and while doing so, while draining into the upper deep cervical lymph nodes, the lymphatics they have to pierce the thyroid membrane. And below the vocal cord, the lymphatics they have to drain into the prelaryngeal and pretracheal lymph nodes, and finally they have to reach the lower deep cervical lymph nodes, and while doing so they pierce the cricothyroid membrane. So we have said about Rima glottidis again and again. Now let's see what this Rima glottidis is, what are the boundaries, and how it is connected to the phonation. So Rima glottidis, as we already know, is the narrowest anteroposterior part of the laryngeal cavity. Now we have to define how narrow. So for that we have to define the diameter. So anteroposterior diameter of glottis, Rima glottis, is 24 millimeters in adult males. That means the smallest possible diameter of the internal diameter of the larynx of an adult male is 24 millimeters. And what is the anteroposterior diameter of glottis in females? It is 16 millimeter. So What are the boundaries of Rima glottidis? In front, it is bounded by the angle of thyroid cartilage. In front, it is bounded by the angle of thyroid cartilage. You remember the angle of thyroid cartilage like this part. In the front, it is bounded by this part, and behind, it is bounded by the interarytenoid folds. Yes, and on each side, we have seen in the picture that there are vocal folds above and vocal process below. Now for the this is not important that much for MBBS, but to understand the next slide you need to know that Rima glottidis, it is divided into intramembranous part, intermembranous part and intercartilaginous part. Okay. Now what is the shape of Rima glottidis? In order to form the voice, the vocal cords undergo movement. So in order to form the voice, the vocal cords, they undergo movement, and the movements vary according to the needed voice that needs to be generated or will be generated as the subsequent actions of the larynx. Yes, the vocal cords will determine the movement of the vocal cords will determine the shape of this Rima glottidis. For example, in quiet breathing, so these are sometimes asked as MCQs in postgraduate exams, but for MBBS you should be just familiar how it looks. So we will just go through this simply, the type of action and the type of shape. So for quiet breathing there is pentagonal structure that is formed, and in full inspiration there is diamond shaped structure that is formed. In full inspiration there is diamond shaped structure that is formed, and if there is a high pitched voice, high frequency voice, then there is just a linear very thin line that is formed due to adduction of the vocal cords. When the adduction of vocal cord means bringing both the vocal cords towards the midline. And when there is whispering, that time during whispering the Rima glottidis will become inverted funnel shaped. Inverted funnel shaped. Let's see from the picture. So here this is the picture. So during quiet respiration you see the shape. This is the shape. During speech it is slit like. During whispering it is more slit like. Uh, it's inverted funnel like, and forced expiration you see a inverted like a diamond like with a, this is the anterior side, this is the posterior side. So now let's understand what happens in phonation. At the level of MBBS you should just be familiar with this phonation or speech production. How does it happen? We already know, because of the vibration of vocal cords. So first the vocal cords have to be adducted. That means these are the vocal cords on both the sides. Yes, they have to come in the center. They have to come in the center. So it will become like they will be very near each other. They will be very near each other. Yes, on abduction, adduction. This is adduction when they are coming in the center. So like this is one vocal cord, this is another vocal cord. This will come inside and this will come inside, and what we will have? Adduction. Okay, so first step is adduction. Now what will happen? Because this is adducted, so infraglottic air pressure will be generated. Why? Because the air from the lungs cannot be expelled out. So there is a lot of air in the lungs. Yes, and the next step is this all this accumulated air will force the cords to open. So air will come from below and the cavity is closed. Air is coming from below like this. The cavity is closed. The lungs are here, both the sides. Now when the air is coming, the cavity was closed because the vocal cords were adducted in the first step. So now this forced air, the air will go in force and it will open the cords. So the cords will be opened in small parts. Means एक puff gaya, cords have opened. Another puff goes, cords are open. When the moving air this passes through the vocal cords, there is vibration and production of sounds. Just like you have seen the wind chimes, when forcefully the air goes through the wind chimes, we have different frequency of nice sound being produced. So just like that, the vocal cords, when the air will forcefully pass through them, then we will have the production of air. Production of voice. Now this is just sound is produced. When the movement of lips, tongue and palate pharynx will happen, that time it will be called as the speech. Now let's see what is laryngoscopy. Laryngoscopy is the inspection of the interior of the larynx. It can be done by a device called as the laryngoscope. It can be direct or indirect. Yes. So now what all we will see from above downwards, when we look through the laryngoscope, we see the base of the tongue, which we cannot see here. In this, we see the base of the tongue, the vallecula, the epiglottis, and aryepiglottic folds. All these structures the ENT surgeon can see. So let's just see the picture ahead. This is the one type of laryngoscope. This is the device called as the laryngoscope. They come in different structures because you know the internal diameters of the larynx are different. Now this, you see the pearly white things, they are nothing but the true vocal cords. These are the true vocal cords. Now this is the hand drawn picture I have taken. This is how the anatomical parts are seen on laryngoscopy. So this is anterior, and this is posterior. So now here you see these are the pearly white vocal cords. This is the epiglottis, and uh, this is the entrance of the laryngeal inlet. Going down, we can see the rings like this. These are the tracheal rings. Okay, going ahead, this is when the vocal cords have abducted. Abducted means gone away. That time the laryngeal inlet is open. Now in this picture, these are the vocal cords. They have come close. They have come close. So this is the adduction. Now the last slide, this is the clinical case which sometimes can be asked. So in this case, what is described, that an alcoholic person who goes to enjoy for a dinner party with his family, he is an old person, he takes 4 5 pegs of alcohol, and while eating dinner he starts suffocating, he and collapses on the floor. The wife doesn't pay much attention because she thinks that probably the husband has had very much lots of alcohol because he is a known alcoholic. But the daughter, she is a final MBBS student, and she thinks that the pulse, she checks his pulse and finds that the pulse is very strong and the face has cyanosed, that is become blue. So she knows that the daddy is suffering from asphyxia. So she opens the mouth to see why there is a asphyxia, why there is shortage of oxygen, why shortage of breath. So she finds out that a piece of meat is stuck. She tries to remove the piece of meat with her finger, but it is not possible. So what she does, she holds daddy from behind, keeping both the hands in such a way that she interlocks the hands in front of the epigastrium and exerts pressure from behind 2-3 times. And what she sees that the meat piece is expelled out. So this is the case that the food is impregnated inside the larynx. The technique that she does is the Heimlich maneuver, and then certain questions will be asked to you, which is the narrowest part where the food can be stuck. So that is the Rima glottidis. You have to describe the case, what is affected. There is foreign body in the larynx, and asphyxia has happened. Then what else you can say? They can ask you about Heimlich maneuver. So you should be able to answer all those questions. So thank you very much. And if you have any questions, write down the questions in the comment box.